Okay, good morning, guys. It's 8:03, and according to, well, just to try to keep us on track, because Dr. Warner likes to start promptly. We were 3 minutes late, and my apologies, but first we're going to start with Don Raphael Wynn. He's our neuro-ophthalmology fellow, and he's going to be talking about spinocerebellar ataxia type 7. So without further ado, if he can come forward, and then we'll have several other presentations this morning, and we'll kind of talk about those as we go. So,
Start.
Okay. Thank you, everyone. So I'm going to talk about spinocerebellar ataxia type 7, and I have no disclosures. Okay, so the basics about spinocerebellar ataxias in general, we call them SCAs for short. They're diseases that are they're neurodegenerative hereditary diseases. They mainly affect the cerebellum. And they result in ataxia with dysarthria. People have difficulty with swallowing, and they also get pyramidal signs from corticospinal tract involvement. And there's about 40 types described in the literature. And keeping it original, they name them SCA 1, 2, 3, 4, all the way to 40. They basically name them as they're characterized and discovered. So SCA 7 is basically the seventh SCA that was characterized. And the importance of SCA 7, the reason I'm talking to you guys about it is because it's associated with retinal pathology, which is unique for the SCAs. So this is a normal MRI on the left, and then a patient with spinocerebellar ataxia type 2 on the right that I saw in clinic as a resident. And what you can see is that the cerebellum in the, let me see if I can get this to work. And this normal patient kind of fills this area right here, and it looks nice and plump and juicy. And then over here you have this really small cerebellum. There's a lot of leftover space right here, and there's a lot of space between the different lobes and portions. And then this pons right here, this pontine belly, is really flattened out compared to this nice big fat one right here. So that's the main characteristic and feature of spinocerebellar ataxias. This just kind of reiterates that point. So this is kind of an axial cut of the pons and the cerebellum, cerebellar vermis right here, middle cerebellar peduncles, and it's just kind of atrophied down in this patient with SCA 7 over here, this being a normal control. And then the pathology, this is a normal example slice of the cerebellum. We have these three layers: granule cell layer, these Purkinje cell layer with these large, this might be hard to see, but these large cells right here with this little nuclei in the middle, they kind of line the granule cell layer right here. You might see a couple of them. And then this molecular layer. What we see in spinocerebellar ataxia, and this is from one of the patients in our series, is they have the granule layer and the molecular layer, but they're missing those Purkinje cells around that granule layer. So we described some of the neurologic issues, what's going on with the eyes. All right, so we have this early degeneration of photoreceptors in the retina, and it causes this early color vision impairment, specifically affecting the blue-yellow axis, causing a tritan defect. Later, the cone rod dystrophy progresses till they have pretty widespread retinal disease, and they have tremendous visual impairment with central scotoma. The macula takes on this kind of mottled appearance. Some people describe it as a beaten bronze appearance, and I'll go into that in a little bit. And then because of the cerebellar degeneration, patients will have a variety of eye movement abnormalities, including slow saccades, restriction of eye movements. So this is the color testing that we do. So we have this Farnsworth D15 color sorting test, and what these people do is they take this test with these little colored chips, and they put them into the specific order that they're supposed to go in, right? So this red goes close to this kind of red-orange, and then next you put in like an orange, and so on and so forth until you get this nice kind of rainbow arrangement. And so normally, someone will put 0 next to 1, next to 2, next to 3, and so on. And you can see this person has normal color vision, at least as far as this test will pick up. And then over here, this is someone with a protan defect where they don't have any red cones, and they'll connect 0 to color 15, to color 1, to color 14. Similar with kind of a deutan defect, a little different though. But then there's this very unique appearance to the tritan defect where when they get to color 7, they start mixing it up in this orientation. And that defect is, it's not unique to spinocerebellar ataxia type 7, but it's not something you'll see in a normal individual, and it's not something you see in many other diseases. And so for the residents, dominant optic atrophy is another one to think about with this kind of tritan defect. And I lost my screen. There we go. So this is the test from one of our patients, and you can see she has this very classic tritan defect. She later developed really profound color vision loss, so this is one of her early visits, and then later on she couldn't do any of the Ishihara plates, and then later on after that she had a large central scotoma with 2200 vision, so it just gets progressively worse. What's interesting about this is in the case series that we did, we had these 10 patients from this large family. And one of them is a young girl, about 9 years old, and her mother had SCA7. Her father had been with the mother to all of her clinic visits, and he had seen all the testing that they did, including this D15 testing. And he got called by the teacher, this girl's teacher at school, who was saying, you know, it seems like she's having some problems seeing things on the board or making things out. I'm not sure what's going on. I'm not sure if she's just misbehaving. So this kind of startled him because her vision being affected, given the family history of his wife, of her mother, this got him understandably kind of worried. So he actually sat her down at a computer. He remembered this test and its name, and he found an online version of this that the girl could do, where she just points and clicks, drags different colors over, and sorts them. And then you click a button, and it tells you how you sorted them and gives you one of these maps, and actually got one of these maps with both eyes after testing her. So he brought her in to clinic, had her evaluated. She had some very subtle findings on exam, none of the ataxia cerebellar findings, and sent her samples over to the NIH. They tested her, and she was positive for SCA7. So this is sometimes, you know, one of the earliest findings you'll see in these patients. It's kind of a neat, sensitive clue. And then we often will get a multifocal ERG on these patients, and you can see this tremendous depression in both eyes compared to the normal controls. So I don't know how good this is going to come out, but I have a close-up. This is that same patient. I'm using the same patient for all of these. This is that same patient 5 years prior to this photograph of the fundus. And what you might be able to tell here, and the next slide might be more clear, is there's this kind of modeling, kind of beaten bronze appearance to the macula, to the fovea. And this is a close-up. I don't know how well this will come out, but it kind of has this beaten bronze appearance to it. This is interesting too, because in our case series, you know, we knew about this appearance from prior studies and from our prior patients. When we looked carefully through our series of patients, we found that at least one of our patients had this appearance to their macula before they had any visual acuity issues. So this was a patient who came in just to get kind of a checkup because he knew his family members had this disease, and he didn't have any symptoms that he knew of, but looking in the back of his eye, we could see this characteristic appearance. His visual acuity was actually 20/20, but then when we did the D15 color sorting test, he had that characteristic tritan defect. So this is another really early finding that you can sometimes pick up with these patients. And you know, by itself might not mean a lot, but if you see this in a patient who comes from this large SCA7 family, then it might lead you down that road. So going into the genetics, this is an autosomal dominant disease, and as you'll see with this family tree in the next slide, it's very autosomal dominant. Every generation's affected. And it's caused by an unstable CAG trinucleotide repeat, kind of similar to Huntington's disease, where there's this trinucleotide repeat that results in anticipation. And we saw that anticipation with our family, with our large family as well. One other interesting thing that's been found, and this was demonstrated by Johansson et al., was that these, on average, patients will have 38 to 70 repeats. When they get greater than 59 repeats, they're more likely for some reason to present with vision loss before they develop the ataxia. And so the older generations in this family and the older generations in other families studied tend to present with ataxia, whereas their younger generations tend to present with vision loss. So another clue you might get seeing patients like this in clinic is going through a past medical history and finding that no one else has vision problems, but grandma has this balance issue. And this was borne out with our case series as well. So this is a family tree, and I've really only included kind of the pairs of people that were affected. It's much larger than this, the whole family tree. But these are the affected individuals, the ones that are shaded in with blue, and the ones that have numbers here in the third, fourth, and fifth generation. Those are the ones that we were able to include in our case series. And so we had 2 from third generation, we had 5 over here, and then we had a couple down here in this 5th generation. And what we found paralleled a lot of these other studies. There's this anticipation where these patients presented at younger ages and typically presented with more visual complaints before they developed the ataxia. Eventually, they all develop really profound vision loss. Eventually, they all develop really profound ataxia, except one patient who hasn't gone on that long, the 9-year-old girl that I was describing earlier. She has not yet progressed to any of the neurological findings. So, like I mentioned earlier, we found that same anticipation that was described in prior case series. We also found that the younger generations tended to develop these visual symptoms earlier on. And it may be in part because people are looking for those visual symptoms, and that tritan defect is a really kind of an early finding in almost any of these patients. But one new thing that we found is that beaten bronze appearance to the macula is something that you can see very early on in the course of this disease, and that it can sometimes manifest itself before they've actually had any tremendous loss in visual acuity. So, what's next? We're enrolling these family members in a study done by the NIH. They're kind of further characterizing this by taking all the large families throughout America, and that includes our big family here in Utah. Some SCA diseases, not SCA7, but some SCA diseases are being studied right now for possible genetic therapy, and that includes studies with interference RNA. A big researcher in that field is Dr. Stefan Polst in neurology. And then I didn't show any of the retinal pathology that's been described in the literature before, but one of the patients in our large family has said to help further the knowledge of this disease, she is donating her eyes when she passes away. And I think she's been diagnosed recently with a grade 4 metastatic carcinoma, but she's dedicating her eyes for further study. So we anticipate in the next couple of months we'll be able to get that tissue and we can learn a little bit more about the pathology. And that's all I have. Are there any questions?